and it's thought to spread through droplets that float in the air when someone coughs or sneezes. It's also possible for that to happen even when someone doesn't have symptoms of the disease. So someone can be infected with the disease, they can be in the incubation period before they're experiencing symptoms, and yet they can still spread it to others. How much that's happening is something that's still being developed. And then there's also spread with respect to contaminated surfaces. You probably read a little bit about how the virus lasts on different surfaces for different periods of time. It's one of the reasons why disinfecting has been recommended so heavily. And then lastly, different viruses not only spread through different means, but they spread at different levels of ease. And this virus is thought to spread very easily, which makes it easy to be sustained within a community. I'm conversant in epidemiology. I am not someone who's trained in it, and so I always am relying on the CDC, the World Health Organization, information from the Illinois and Missouri Departments of Health. That's the best place to pick up information, certainly not social media. I did scour a little bit to find what are projections for infections, hospitalizations, and deaths in the United States, and you'll find all sorts of different projected rates, from 20 to 60% infection rate, which essentially is taking that percentage and multiplying it by the US population. The American Hospital Association, that is quite concerned about hospital resources, is using a 30% rate, which would project out to 96 million Americans being infected. Now, not all people who are infected end up becoming so sick that they need to be hospitalized. I've seen 2 to 20% hospitalization rate projections. Again, the AHA is using a 5% rate, meaning about 4.8 million Americans being hospitalized. And mortality rates, we're also trying to discover, again, just going through some literature, there's all the way down to 0.2% up to 6%. Right now, the latest information from Italy suggests a 7.2 mortality rate. So there is quite a range there. So why does that information matter? You hear about flattening the curve, and the top picture on this slide gives you a sense of what that means. This is the curve we're talking about. And if you imagine, right, that the vertical axis as being the number of infected people, and that or the horizontal axis being time, flattening the curve is taking the total number of infections and spreading it out over longer time with the goal of preserving healthcare system capacity. So hospital beds, within hospital beds, ICU beds in particular, ventilators in particular, gowns, masks, and then of course hospital personnel, physicians, nurses, techs, and others. So that's what's meant by flattening the curve. And that's tied into the social distancing orders, the quarantine orders, the isolation orders that we're seeing. It also potentially has the effect of reducing the total number of people who are infected. But at the very least, having this disease spread more slowly is one strategy for keeping the healthcare system from being overwhelmed. The bottom right-hand picture is a projection of when ICU beds will become in short supply in various states. And you can see that there's different dates. I wouldn't put too much stock in what you're seeing in this particular map now, because we're really at the early stages. It's highly likely that there's many more people infected in Illinois, Missouri, and across the country than we really have the numbers for yet. And that's because of the incubation period. So these numbers will change significantly as we learn more, as we see more in cases. I think the numbers become more reliable in another week or two. Law and policy issues, oh my goodness, there's plenty. I'll start with the ones that we're seeing. Orders by state and local officials, the stay-at-home orders, and I'm going to distinguish these here. Sort of mass social distancing is one kind of order. Quarantine is a different kind of order, and isolation is yet another kind of order. You hear about all of us saying, oh my gosh, I'm isolated at home. Well, no. Tom Hanks was isolated, that's because he was sick with the actual disease. So isolation refers to separating someone off from all other people who are not sick or have been exposed, but we're not sure if they're going to get sick, because those people are in fact infected. Quarantine is separating people from the general population who we know have been exposed, and we're waiting to see if they become infected. The mass social distancing orders that many of us are under right now aren't like quarantine or isolation, which are identified at small groups or individuals. Here, mass social distancing and stay-at-home orders are used to protect the population at large from a disease that's got a foothold in the community. And we don't know yet we don't know enough about how the disease is spread to easily identify who's been exposed and who's been infected. All of these are being used at the same time. Support for mass social distancing. So another huge law and policy issue, and you see the federal government acting on this as well as state governments, is trying to provide people with the necessities of life in order to make it more possible for them to cooperate with the mass social distance orders. I mean, think about it. St. Louis City, St. Louis County, St. Charles County, and other counties in Missouri have said we need to stay at home, not go to work except for essential businesses and essential functions. There aren't enough police officers that if we all decided to run out into the street and have a big party together within 6 feet of each other, not that I'm recommending that, that the police could really get around to getting everybody back or could guard every house. So cooperation is key. So support for individuals who are cooperating with those orders is also key. That has to do with income. You've read about federal law, a new federal law that would get checks to Americans. But it also has to do with applying for income support as a result of being unemployed. We've seen numbers just today that just in the last week, the numbers have jumped by tenfold from under 300,000 unemployed applying for income support to over 3 million today. Housing support, that includes things like mortgage relief, rent relief, laws that would suspend any sort of repossession or foreclosure on a mortgaged house or evictions on rented property. Keeping utilities going. You've probably seen gas, electric, water. We will not suspend your services even if you're late on making payments. Telephone, the same thing for communication. And of course, internet. With internet, it's not just cutting it off, it's making sure people actually have access. One of the main ways we're keeping transactions going, one of the main ways we are communicating with each other with data about the spread, about policy, and just keeping in touch with each other as we're staying at home is through the internet, through broadband. And then another step is thinking within those categories of the most uniquely vulnerable, the poor who might not have had internet to begin with, who may already have had utilities shut off, who might not have adequate housing. The disabled who need additional help. Are they getting that help in-house? Are they getting it when they need it? The elderly, similarly, if they're not able to take care of themselves, they seem particularly uniquely vulnerable to the disease. If we're talking about nursing homes, retirement communities, they're living in closer quarters. And so there's a better chance for the spread to take hold in that smaller community. Homeless populations, where are we sheltering them? And existing shelters probably don't have enough room to follow social distancing guidance. And so we need to open more and keep in mind that the social distancing requirements. What about jails and prisons? We're seeing that St. Louis County is releasing certain inmates from the county jail who are perceived as non-threatening in order to create more space inside the jail in order to abide by social distancing. These are just some of the issues that are arising. As we move forward, this is going to be an important slide to remember the structure of how authority works and what its limitations are. Right in the center, state police powers. State police powers don't come from the federal government. They don't come from the federal constitution. They come from the sovereignty, or the one-time sovereignty of the states. It's reserved by the 10th Amendment in the federal constitution. But police powers just simply exist by virtue of sovereignty. And so that's why you're seeing states and governors as the ones issuing orders. The police powers, the power to protect the health of the people, their welfare, their safety. And so you're seeing governors take those sorts of actions, or health officials at the state level. As you follow the blue arrow down, states can delegate that authority to cities and counties. And so we're seeing the city of St. Louis, the county of St. Louis issuing its orders. That's based upon a delegation. The red boundary that goes around is a limitation. State police powers don't authorize states to do anything they want. The federal constitution applies. And so the Bill of Rights and all of its limitation would apply to any exercise by a state or a city or a county of its police powers. And then the cheese holes that you're seeing and the arrows that go up have to do with the authority of the federal government to take action. So for example, the acts that we're seeing coming out of Congress now, those are tax and spend, right? Taking money collected through taxes and spending it for the general welfare of the United States by sending out checks, by requiring mortgage holders to provide relief. And through federal supremacy, that would supersede any state laws, including state laws that are based upon the police powers. But generally speaking, the ability of states to issue these orders is significant and not going to be overridden by federal law unless they are deemed unconstitutional. And that brings me to this slide. Very recent challenge in Pennsylvania. The governor there has issued a variety of orders that we're seeing across the state in terms of staying home. A number of businesses have gotten together and they're challenging that order on the basis of the red boundary I drew around the blue box, citing to various amendments to the federal constitution, First Amendment, Fourth Amendment, Fifth Amendment, and 14th Amendment. And that will be subject to challenge, and we should be watching for that to happen more often. So law students, as you're thinking about this, think about it in terms of authority and limitations of authority. Think about federalism, state level, federal level, and delegation to the local level. And then as we go, and you're reading a bunch on social media in the papers about policy proposals, one of the things we have to do is make sure that every policy is based upon the data, at least the best data that we have. And that's why it's important, even as a law professional, to be checking in with the CDC, the Missouri Department of Health and Senior Services, the Illinois Department of Public Health, to learn the latest update of what we know about this disease, the way it spreads, and the protections that we can use against that spread. So that's the end of my portion of this, and I hand it over to Professor Rutschman to talk about medical technology.
Well, thank you, Professor Gatter, for this overview of the many ways in which the law is relevant and data-informed policy is relevant for all of us at multiple levels, from our little localities to regional areas to countries and eventually the entire world. Get through this. And get through this, we will. That's what we know from history, from previous outbreaks, and from science. And there's a couple of ways in which this outbreak may come to an end. One is slightly better than the other, the two options that I'm going to survive for you, but ultimately they depend on not just our complying with all these, again, data-informed policies and laws that are in place, but having some sort of technology that might enable us to fight this particularly nasty virus in a more effective way. So how does the outbreak come to an end? Professor Gatter mentioned the idea of flattening the curve, and we can do that in a number of ways, and some of them are faster. The possible, well, technically impossible right now, but the idea that we can stop transmission by generating immunity, global immunity to the virus would be the fastest way to stop this outbreak. Without something that cuts transmission short, be it social distancing or something like a vaccine, the outbreak will come to an end. We'll eventually become immune simply because so many people will be infected that herd immunity, the idea that there are not enough vectors to spread infection anymore, will settle in. So things are going to come to an end. The idea is, how fast can we make that happen for all of us in the US and elsewhere. So when Professor Gatter went through these measures that states, the federal government, institutions like the WHO that coordinate things at the international level, when Professor Gatter went through all these measures, we are essentially trying to promote one, social, I think now we call it physical distancing. That's what the WHO is calling it. So we're stopping infection by making sure that people are as apart as possible and by tending to those who are already infected. Other possibility, and from SLU medical and research campuses to literally almost any country in Europe, Northern America, and parts of Asia, scientists are coming together to develop both vaccines and treatments for coronavirus. Now, those of you who've taken some of my classes know that this story is not normally uplifting, right? Because developing something like a vaccine or a treatment takes anywhere from 6 to 7 years, good case scenario, to 12 or 15. But there are some really good news in the context of infectious diseases, and particularly with regard to the coronavirus. So right now, coronavirus, the most detested virus we collectively know of. In fact, however, and it might sound slightly strange to be phrasing it this way, but coronavirus is not particularly aggressive as far as viruses go. So unlike things like Zika, which we became familiar with very, very recently, coronavirus does not mutate that fast. I'm not saying that the burden of COVID-19, so the disease caused by coronavirus, is not tremendous from a public health perspective. It is. But from a scientific perspective, the virus is one we kind of understand, even though the strand is novel, and is one that we have technologies, primarily vaccines and things like antivirals we've used in malaria and HIV context. So we have those things already. And that's why you've possibly seen slides or articles like the one currently on the slide saying, hey, scientists are racing to develop a new vaccine or a set of new vaccines that would help us flatten the curve, and instead of like this, sort of like this. So the idea that we would not have to wait for about 70% of the world to be exposed to coronavirus and hence for herd immunity to kick in, that we can fight the infection spread through technology. So how does this happen? How do we get to have vaccines so quickly, and does the law have anything to do with it? First thing I would note is that you might have heard about some tensions when public health officials and parts of this administration talk about a vaccine coming to the US. And even under this very uplifting scenario from a vaccine development perspective, you know that probably the timeline is not going to be below 1 to 1.5 years. So when we say we're going to have vaccines pretty soon, I don't mean tomorrow, unfortunately, nor by the end of the summer. But we're going to have vaccines at an expedited timeline for R&D, and eventually they will be made available to us. There's already a couple of ways that, if you're familiar with the pathways for us to normally bring drugs to market, that are already at work for this to happen. So normally, those of you who've studied these fields, and even those who have not, and Professor Gatter, if I could get the next slide. So if you know anything about drug development, you know that normally we have mathematical models that we try to play out and see if a drug might work or not. And we try a drug on populations of animals that are close-ish to humans. And then we finally try it in a very small group of people, then a slightly larger group of people, and then a really large number of people. And if everything goes well, eventually the FDA will approve the vaccine after many, many years, and peer-reviewed studies will have been produced. Now, you might also have either heard or seen on TV images like this one. We already have a human clinical trial going on. This was the first one, which started in Seattle, and there are multiple companies, not just in the US, but across the world, starting similar clinical trial processes. So FDA and counterparts to the FDA, such as the European Medicine Agency and in Europe, they are using different sets of rules that they deploy in contexts like this. This is not to say that we are trying to let products of inferior quality or potentially dangerous products come to market, but because we're relying on very similar technology, so vaccine technology that we've used in the context of, say, Ebola, the flu, and a few other diseases, we know that we can adapt those types of technologies to the needs posed by the new coronavirus. So FDA is, through emergency order provisions, they're allowing tests that normally would never ever take place so quickly to already take place. And we've had, this is I think a heartwarming story, we've had a lot of healthy volunteers coming to Seattle, which, as you know, is one of the epicenters of the outbreak, coming to Seattle and volunteering to be on those trials, even though you know that the timeline for the development of these drugs was extremely small. So there are a lot of unknowns, and there are greater risks in principle that normally our regulatory system would tolerate. But we tolerate those risks right now because, on balance, we think from a public health perspective, it's okay to tolerate those risks. And from a scientific perspective, we hope that these vaccines do work. So imagine that a year goes by, we've somehow flattened the curve, and the vaccines come to market. Ideal scenario, everybody who needs access to this vaccine will get access to it. That's the public health ideal. Unfortunately, and this is where the story turns south a little bit, under current US laws, there's no guarantee that the vaccines will be affordable, even though a lot of the research on which the development of these vaccines has been funded through US taxpayer dollars, and even though the law says that in those cases there have to be a number of negotiations regarding things like price. Are you going to sell the vaccine at exactly the same price all through the country? What to do about populations that are not insured, for instance, or are underinsured? How are these vaccines going to get reimbursed through our system? So there is a number of questions that need to be discussed, and that the law says have to be discussed in advance, and they have not been discussed. They're not being discussed, and we know from previous outbreaks, this happened with Zika, this happened with Ebola, the public agencies involved in supporting this development have tended to shy away from those negotiations. They have tended to say, we don't know how to do this. We don't have the know-how internally to do this. So I dearly hope that some of you will end up working at some of the public institutions that need this sort of licensing quality check when we bring such critical medical technologies to market that can help us really not just, you know, flattening the curve a little bit, but bringing infection levels to zero, because that's what vaccines are capable of doing. I hope that either some of you or people in this space will eventually come to apply the Patent Act and other laws that are relevant here to make sure that the vaccines will indeed be affordable. On the field of medical technologies, and Professor Gatter, if you could just get us the next slide, I think that it would be nice for us to talk about something even more immediate application in the outbreak than vaccines, and then this presentation on an uplifting note, because what I have for you now is actually a happy or sort of happy story in the midst of all the suffering that coronavirus infection has caused throughout the world, but particularly in Italy. So these two gentlemen you're looking at right now, they're engineers, and you might see at the bottom of the picture the word Isinova. That's a company in Italy, in the city of Brescia. And Brescia is located between Venice and Milan. So if you've been following the events in Italy, this is the epicenter of the Italian outbreak. So these two engineers, and they have a little startup company in the city, and they heard that the local hospital, similar thing to what we predict might happen here, was running out of beds, was running out of ventilators, but even more important, in the cases in which they were using ventilators, the valves that you need to connect the ventilator to the patient were pretty much wearing out. So what you see, the gentleman in the wine-colored shirt, red wine-colored shirt, holding, those are the valves that we are talking about. And they can go for a number of hours, about 8 to 10 hours. They can go for that long, but they were running out of those in the hospital, even though they had a certain number of ventilators. Now, as some of you might have taken some of my other classes know, medical technology is pretty much patented through and through. So sure enough, the valves were and are patented. And the company that supplied the valves, not the ventilators, but the valves to the hospital, charged just over 10,000 euros per valve. As you can imagine, this is not a sustainable business model, probably not under any circumstances, but especially not during a pandemic. And they were not shipping valves to this Russia hospital, nor was the hospital able to source them from anywhere else. So cueing these two gentlemen who read the newspaper and heard about what was happening, they realized that they had a 3D printer and they had friends with 3D printers. And they realized that the medical technology in question here, in many ways like vaccines, which are not very complicated to make, they just take time, this strikes me as a pretty simple form of technology. And Professor Gatter, if you could just show us the final slide, please. So this is what the valves look like. And these are 3D printed valves that these two gentlemen and then a few other people who joined in, all of them with access to 3D printers, they were able to 3D print this. Now, here's the twist, and this is how we come back to the role of the law. Because all of this is patented, they contacted the company holding the rights over the ventilators and the valves, and they said, well, can you send us the design of the valves so we throw that into our programming and we have the right codes that will yield these valves? And the company said, no, we will not do that. Why is that? Because if something is covered by a patent, you do get to say no. There are very few provisions, even provisions at the international level informed by the Doha Declaration on Public Health. There are very few things that we can actually use in a pinch and force people who have patents or other types of intellectual property rights over these products to allow others to copy. So the company said no. What did the two gentlemen do? They reverse engineered the valve. So keep in mind, this works for a valve. It will not work for something more complicated like a full ventilator, for instance. But they were able to do it. And in 6 hours, they had about 100 valves, and locally they keep supplying the hospital. So this is a very uplifting story. Keep in mind that were the law to be applied as it normally is, they would have incurred in a number of things, from copyright infringement, just because they replicated the instructions on the 3D printer, to patent infringement because they copied, and that's the standard, they copied the design and possibly they replicated the process that you use to create these valves. So you have a branch of the law that's meant to give us treatments, cures, medical technologies that completely stood in the way of this happening, and just by sheer disregard of the law were these gentlemen able to solve a critical public health problem at the epicenter of the Italian epidemic. This is coming our way, right? As Professor Gatter was mentioning, the shortage of beds of medical technologies. So this is a particularly good time for us to be worried about how the law, instead of facilitating responses to outbreaks, may also stand in the way. Quite frankly, because many of the laws regulating the development of these technologies are either international or so complicated that amendments would have to occur at this point for the legal framework to change. There's really nothing we can do immediately to change the law. But again, the outbreak will come to an end, hopefully sooner rather than later. So these are some of the things to keep in mind. When we all resume something that resembles more of a normal lifestyle, one of the roles for you, one of the roles for lawyers, policymakers, advisors, is to look at these laws that, you know, whenever the next outbreak rolls around, and fortunately we know this is not an if, right, it's a when situation, we probably, I would say, should amend these laws and make sure that when a public health crisis arises, we are ready and we have the legal tools to respond to that. And I think I will end here, and we've left, I think, enough time for questions.
Yes, we have, although Professor Gatter is going to need to unmute himself at this point. And for those of you in the audience, if you'll go to your Manage Participants button, you'll be able to see a panel on your right, where if you raise your hand, you'll be able to ask questions. And I see one from Gabriella. I'm going to unmute you.
Hi.
Hello.
Can you hear me okay?
Sure.
Okay. I just had a question regarding ventilator supplies for people with disabilities. I know a lot of people are really concerned because when you use Medicaid and you need complex medical equipment like a ventilator on a daily basis, Medicaid doesn't just give it to you, they like kind of rent it to you on a monthly basis, or they reevaluate however often. And a lot of people are concerned with the ventilator shortage, that ventilators and other things like that are going to be taken and redistributed based on like a triage system. And there's been a lot of news about triage systems not putting people with disabilities at the beginning of the line. And so I was just wondering if that's like a realistic fear, or if you've ever seen that happening, or if you think it could, or kind of what you guys think about that.
I think it's a realistic fear, and other than like you reading the news, all my knowledge in this area comes from what I hear from Professor Pendo, who seems to be reasonably concerned with particularly how people with disabilities are being or will be affected by the shortage. So she's a good contact if you're specifically interested in that topic. That's certainly one of the things she's looking at right now. In terms of the sheer supply of ventilators, there's very little we can do at this point. We can intervene in little areas like getting valves, for instance. If it's the parts of the ventilators that get worn out the fastest, there are ways for us to get those, and that's the case that I just exemplified. So there are some things we can make sure that happen, but no matter which data you're relying on, the indications is that we will come to a scenario of shortage pretty much across the country.
Let me add that Professor Pinto had a conflict today and she's not with us, but we are planning a second in this series with Professor Pinto, and one of the things she wants to address is this issue of that's being discussed around access to ventilators, and a concern that many people are expressing that some of the systems that have been proposed do put at risk people with chronic conditions and disabilities, and we do intend to address that specifically in another conference. So thanks for asking that, Gabriella.
I want to add that there is a national stockpile of medicines, equipment, and it includes thousands of ventilators. And I know that the federal government is starting to distribute some of those. You may have heard Governor Cuomo being concerned that he thinks the state of New York is going to need 30,000 ventilators total, and not 30,000 from the national stockpile, but 30,000 total. And that right now, New York has received 400 through FEMA. So you can watch for that. And I know that there are healthcare professionals working on ways to figure out if they can use ventilators to essentially to share for some patients.
Okay, thank you very much.
Thank you. Next in the queue, we have Brian Earl. And let me just again say, if you raise your hand, it creates a queue and I can see you and I'll go in order. So Brian.
Thank you. So there's been some talk, and I think it's obviously sort of political, but it seems like there may be some truth to the idea that at some level, the cure might become worse than the overall issue. And so I'm thinking about particularly low-income people who've essentially been told, you can't go to work, and it looks like there might be some low-level help from the federal government. But at what point do the social determinants of health start sort of hurting people more than the people we're saving? Because I think it's people who are already unhealthy who are being most affected by these orders to shut down. So while I think maybe the conversation has gotten a little political, it does seem like there might be some truth that at some point we're going to hurt people more than we might be helping them. How do we find that line?
Yeah, that's a great question, Brian, and there is a debate going on. And I think you were saying, oh, it's becoming somewhat political, but it is a balancing. And I think one of the keys is, I can think of two really important things. One is that we need to learn more about how the disease is transmitted, how much is coming from people who are asymptomatic, how much is coming from contact within 6 feet, and how much is coming from various kinds of infected surfaces. The more we know about the disease, the easier it is to spot places where we can scale back in our distancing, scale back in the number of businesses that are closed and how people interact with businesses in order to allow that to happen. I read recently in the St. Louis Post-Dispatch that several restaurants that remained open but switched to pickup and curbside nonetheless decided to close. And they did so because their workers were fearful that by reaching into somebody's car, they were subjecting themselves to infection. Look, if in 2 weeks' time we have good data to say that's not what's happening, then I think a number of those open up again. So I think that's really important. The second thing that's really important is we need some way to do widespread surveillance type community testing. We wouldn't have to have the kinds of social distancing orders we have now if we could more readily identify who is infected and who isn't. There was Professor Lindsay Wiley recently put out a thread on Twitter, and it concluded with some home testing kits that are being experimented with. I mean, that would be fantastic if we could get those into the hands of most Americans, because I think we could reshift the very balance that you're talking about.
And one quick thing I'll add to that, we've been going between the short term, which is the social distancing framework we have right now, and I've been talking about the long term, which is vaccines. There's something in between, which is the medium term. We need to think about, and we're thinking about an exit strategy, because this cannot go on forever, even if it turns out that it's the worst case scenario and the outbreak lasts a really long period of time. And I think that when we transition from this short term, social distancing to the max, to this beginning of exit strategy, when prioritizing which things go back to normal or levels that resemble normal levels sooner rather than later. First thing, on top of the list is not going to be a Cardinals game. We cannot have X thousand people come together. But that's, I think, where your comment is particularly relevant, because the idea that some people who are already disfavored on so many levels are bearing such a burden during social distancing, if that idea, coupled with data that we'll have from the coming weeks, does suggest that there are localized areas for us to alleviate the ongoing requirements, that's how interventions should be informed, I think.
And I guess I would conclude those comments that it's not an either or, physical distance or going to work and putting people at risk, but it's also the recognition of this. We've now had one stimulus bill passed and a second one has passed the Senate, which is providing unemployment benefits and food stamp support and a whole array of social support so that people can stay at their homes and can be safe. And I think part of what this pandemic is going to require us to do as a society is to think about the ways we support those who are most vulnerable, who have been living on the margins without paid sick leave, without health insurance and how to provide those supports. So it really is going to make us think as a community. And we may want to look at countries like Denmark and in Germany, who as part of their physical distancing have created social safety nets for the community. But thank you. I've got a chat question from Fawn, who says she's not in a quiet workplace and doesn't want to turn on her mic. But here's the question. From the news, it looks like much of the government response has been slower than necessary to get ahead of the virus's spread. It seems like the American Hospital Association is similarly choosing to base its estimates near the bottom of the predicted ranges. Do the American Hospital Association's choices of low estimates present a concern? Is it possible that this will lead to underestimates of hospital need?
So I'll jump in because I happen to choose those AHA estimates. I think one thing to keep in mind is that nothing's written in stone. So the AHA will update its numbers as we get more numbers. It's difficult. What we're doing here is, on the one hand, making policy on the basis of data, but our data is incomplete, which means our policies have to be prepared to pivot and pivot pretty quickly. So I would, to me, the thing to do is to, make the American Hospital Association a favorite on your browser and check back every couple of days to see what's happening. In 2 weeks' time, we will have the kind of numbers that I think we'll get a better handle on. Using Italy's numbers, for example, that 7.2% mortality rate and the huge hospitalization rate, they're almost false numbers because Italy has run out of ventilators. And so some of the deaths are caused most immediately by the lack of medical support. There are some people who need to be in the hospital who are home. There may be some people who are in the hospital who could have been at home. And so we try to piece that together. I think as we watch numbers expand, particularly in California, New York, and Seattle, we might get a better handle on where those should be. And I do trust that that's what the American Hospital Association is doing. There's lots of interesting modeling going on. And for these kinds of projections, if you've not been on the Health Affairs blog, I recommend it to you. That's a good place to go and see. Another place that I go is a place called CIDRAP, and I'll put it in the chat. And it is, it's a center at the University of Minnesota. And they have a very active website that's updated not just daily, but hourly. And they collect scientific information, opinion pieces, changes in law, and so forth. And so I recommend that to you, as well as Health Affairs, so that you can have that information at your fingertips as much as possible. And what we'll see, and that may make the numbers that the American Hospital Association is using a bit more rational.
So I'm going to take our next question from Professor Emeritus Sandra Johnson, one of the founders of the Health Law Center, from whom we've all learned a great bit. Andy?
Thank you. First, thank you to Anna and Rob and everybody else who made this possible. This has been really informative and efficient. I appreciate it. I have a lot of comments about the way people are describing the populations that are vulnerable to the more serious versions of the symptoms of the COVID-19. I think we do some separating, as we do with people with disabilities, as they are them and not us. And I think if you're serious about the data, you see that the us of those who are vulnerable is actually quite large and invisible. People with lupus or MS or diabetes, or the whole thing, especially juvenile diabetes. But my question goes, Rob and Anna, you both identified as testing as absolutely key in moving us toward the end of this epidemic and moving us out of this temporary stage of social physical distancing and shutdowns. Is there a testing strategy that is in place? Does the power to do this locate federally or on the state level? And is it a supply issue or a execution issue on the testing?
Those are great questions, Sandy, and I wish I had definitive answers to them, but I can tell you that my impression is that it is a supply issue, and both in terms of tests and then laboratories. We've seen over the course of, 2 weeks, a change from having federal labs be the primary source of all testing to federal and state labs to now federal labs, state labs, and commercial labs. So that's helpful. But having enough just simply tests that they're out there and available. Every state then also has guidelines with respect to the use of those tests on the assumption that they're in short supply. We have to triage them in some sort of way. And those have been loosened as we have more tests and then lab testing capability available to us. Right now, it seems like that the emphasis is on individuals who know they've been exposed or have more than one risk factor in terms of exposure, or who are working on the front lines with healthcare workers. But that's not nearly enough and not the kind of risk-based testing. What we need is community-based testing so we get a sense of the numbers, representative numbers of who's infected, and they don't even know it yet. And that kind of testing, I don't think is happening.
Is there, but beyond the supply issue, is there anybody who's developed a strategy for broadening the testing in an effective way? Because eventually the supply issue will be resolved, I believe. And then are we going to dither around and try to figure out how to get it more broadly used and what strategy and what communities to test, that sort of thing?
I'm not aware. There could be out there, but I'm not aware. I know that there have been suggestions from those who think about these things, but not necessarily are empowered to employ them, that there ought to be almost representative sampling, that if there are enough tests in a particular county or a particular state, that you would want to grab a cross-section of the population and test, and another cross-section and test, because you'd get a better picture of the number of individuals who are infected but asymptomatic and at different age levels.
And part of the reason the approach is now so piecemeal and scattered at multiple levels is because the institution or the two institutions that should and would under normal circumstances have had a big role, not pre-outbreak, but when we knew there was an outbreak migrating from Asia to Europe and it would eventually come here, those were the CDC and the FDA, and they could have done quite a bit more than they did, but they just started too late. And part of it, it's because our Office of Pandemic Preparedness went away. And I do believe that with more people in policy roles, these agencies would have started sooner rather than later, and now they're just catching up to the supply problem.
Thank you.
And we are just about out of time, but I think we have time for one last question from Chris Rollins, who I have unmuted. I can't turn on your video. That's up to you.
Well, I'm honored to be a question, so thank you. I guess my question or comments is there are countries that are doing less. There are countries that are doing more. But in terms of the death rate per population, and maybe they're just not testing to know, but places like Brazil, places like Japan, other ones that I've heard of that are doing maybe less monitoring, their death rate does actually seem to be lower. But is that just because they're not doing statistics, or in places that are doing less shutting down of the economy, I don't know if are we seeing a benefit from shutting down the economy versus places that are maybe taking a little more lackadaisical attitude? I see that on the, the news and whatnot for different countries. So, and maybe we just don't know yet. We don't have enough time has passed, but when we're trying to balance things, I was just trying to bring that up.
Yeah, I think you hit the nail on the head. I think it's too soon. You have to figure there's what happened in China, that they're about a month ahead more than a month. Then there's what happened in Italy, which is maybe 3 weeks ahead. And you begin to see how it builds geometrically over time. And then there's the effort to rescue someone before we know what they've died of. And then there are individuals who die outside of a setting where we're sure they've been diagnosed, and you have to retroactively determine what the cause of death was. So I think these numbers are going to take a long time, not a long time, but it's going to take weeks for us to really see it. So it's a little too early to draw cause and effect, or even coincidental relationships between actions that were taken in various states and in various countries, and the effect on things like infection rates, hospitalization rates, and death rates.
So thank you. Thank you to Professor Rutschman. Thank you, Professor Gatter. Thank you for everyone who joined us today. And thank you for your good questions. For the students, before you go, don't forget, we do have registration coming up for the fall, and be sure and contact Amy Sanders, who's happy to help you with that. We hope you are safe. We plan on doing more of these events, and please send us your suggestions on what you want to hear about. And I think you've got a hand clap, professors. So goodbye, and see you soon.